Well, hello, everyone, and welcome to our first roundtable with Innovations in Value. I am DeAndra Harmony, and I am pleased to have an extraordinary panel with us today to talk about the critical connection between diagnostic imaging, value based care, and how we actually manage and measure value in healthcare. So, I'm going to introduce our guests, and then I'll turn it over to my good friend and colleague, Dr. David Gorstein, who will be facilitating this great conversation. So we'll first get started with Dr. David Nash. Dr. Nash has had a distinguished 35-year career at Jefferson University, where he was the founding dean of the nation's first college of population health. He is a recognized global leader in physician leadership education and in promoting public accountability for the outcomes of medical care. His 25 books include the leading texts in both the quality and safety of healthcare and population health. He is a seasoned governance expert who has served on 3 public company boards and spent 21 years as a hospital trustee across 3 different health systems. Today, he is the principal of his own consulting firm with clients across every sector of the healthcare industry. Welcome, Dr. Nash. It's good to be
Thank
with
you. Great to
you.
be here. Day 2.
That's right. That's right. Next, we have Dr. Arnie Michelson, who is the founder and CEO of Sumer Labs. Is that how you pronounce it? Is it Sumer or Asher? How do we say it?
Summer.
Summer Labs. Thank you. He earned his medical degree from the University of Washington and completed his residency at the University of Iowa. He spent his clinical career as a staff radiologist and director of nuclear medicine at, you're going to have to help me out, is
The imaging.
Kootenai Imaging. Very good. Thank you. And he was a co-founder of Nighthawk Radiology. He also represented private practice at the American College of Radiology before moving on to pursue an MBA at Stanford, where he now contributes to the Center for AI in Medicine and Imaging. Welcome, Dr. Michelson.
Thanks. Nice to be here.
Wonderful. Next, we have Dr. Scott Howell, who is the Chief Medical Officer of Imogen Technologies. Dr. Howell was an early pioneer at Nginx, which is Optum's predecessor. He served as CMO at Optum Insight, where he led network and population health. His deep leadership background includes chief and regional medical director roles at AdventMed, AmeriChoice, and the AIDS Healthcare Foundation. He also has completed public health engagements globally for both the U.S. and international governments and retired from the Air Force as a colonel after 25 years of service. Welcome, Dr. Howell. And we also have Dr. Larry Eckel with us, and he is an associate chief medical officer also at Imogen. He previously spent over 20 years at the Mayo Clinic in Rochester, Minnesota, where he served as professor of radiology and neuroradiology, chair of neuroradiology, and enterprise specialty council chair for neuroradiology across Mayo's Minnesota, Arizona, and Florida sites. He was twice elected president of the American Society of Pediatric Neuroradiology. Earlier in his career, he practiced radiology in private practice in South Bend, Indiana. Dr. Eckel earned his MD from the University of Minnesota Medical School and completed his radiology residency and neuroradiology fellowship at Mayo Clinic. Welcome, Dr. Eckel.
Thanks so much.
My pleasure. And then finally, we have Dr. David Gorstein, who works together with me here at our parent company, Starfish Partners, and that's our umbrella. And then INNOVA Health, INNOVA People is the company we both work for together. Dr. Gorstein came to the Starfish Partners family with the acquisition of his esteemed firm, Health Innovations. Health Innovations has been a long time go-to resource for organizations transitioning from volume and fee-for-service models to value-based care delivery and a pop health focus. Dr. Gorstein earned his MD from NYU and followed with a surgical internship at Yale and radiology residency at Vanderbilt. And he is a pioneer in health informatics and clinical innovation. Welcome, David, and I am pleased to kick it over to you so you can begin this conversation we're going to have today.
Thanks, DeAndra. Boy, hearing those introductions, we really put together quite a panel. So very excited to be here. I'm very excited for you all to be here. So thank you. All right, let me kick us off with a little bit of framing. Imaging sits at the center of clinical decision-making. Every day, clinicians use imaging to answer questions, confirm diagnoses, assess risk, and determine what happens next. In that sense, imaging generates some of the most important information in healthcare, but information alone does not improve outcomes. The right information has to get to the right people at the right time. And that's where many of the challenges begin. Radiologists often interpret studies with limited clinical context. They influence decisions, but they don't control outcomes. They recommend follow-up, but frequently don't know whether it even happened. They identify findings that may affect care, but they don't see the downstream impact. Imaging doesn't just reflect care, it quietly influences what happens next. But we really have to connect the full loop. The information that we have before the scan itself, the interpretation of the scan, what is the action after the report, and can we track outcomes over time? We don't always know whether imaging can change care, and we don't know when the follow-up occurred, and we don't often know which imaging insights ultimately created value and improved outcomes. We can distill that all down to one fundamental question. How do we do a better job of turning imaging information into clinical action? Wendy, let me start with you, because we really should start at the point before the study is even begun or interpreted. And you've spent a lot of time thinking about clinical context, whether the radiologist is even answering the question that the clinician is trying to solve. How much critical information is buried in the patient chart and never makes it onto the requisition? And you just take it from there.
Thanks. Well, it's a really good question. And it really starts with the order entry. So when physicians go into the electronic health record and they order studies, there's a drop-down menu and it says like, which study do I want? And then there's usually a drop-down menu of potential diagnoses that they click on to put into the order as to the indication for imaging. And those indications are usually really, really constrained, like rule out appendicitis. Well, that's not a lot to work with as a radiologist. And what the question really is not rule out appendicitis. It's help me find anything acute. So that the reason that the actual question is because that's what's going to help me go down my medical decision-making pathway to get beyond diagnosis into treatment and disposition. So radiologists are really helping primary care and ED and other clinicians move through their care pathway paradigm. And that's where the radiologist is really constrained if you say rule out appendicitis, because we don't know if you think there's low suspicion of disease, medium suspicion of disease, high suspicion of disease, and how confident you are in any other diagnostic information that you have. And the more information that you can give me, the better diagnostic accuracy that I can generate for you. Now, as to your other question about like the EHR, I left practice basically to try to build new solutions for how to navigate the EHR and get at that information that I'm talking about. Because as you know, with the electronic health record, there's no index and there's no table of contents. And so in order to try to find the material clinical context around this patient's history, I'm forced to do a manual search, which I can only do so fast. And radiologists are under incredible to get their work done. And as a result of that, there's an alarm in the back of my head. And after 2 minutes of searching, I need to go and just do the read because I've got 50 of these to do today. So that bottleneck in terms of trying to find that information is where we really kind of can stumble in terms of understanding the clinical context. And if we don't have a really good feel for this patient's acuity, their other disease processes and problem list issues, we can fail to provide the value of added diagnostic accuracy and diagnoses that we can bring through imaging. So that's kind of some of the problem on the front end when we're going about trying to ascertain this patient's clinical situation and then deliver a good imaging product to the providers.
It makes so much sense. I mean, if you don't start with the right context, how can you possibly do an optimal job of interpreting the study? Larry, let me ask you, leading neuroradiology at the Mayo, what information did radiologists most often need, but didn't have at the time of interpretation?
Yeah, thank you. I think one of the biggest things that's missing is actually what was kind of just discussed. What's the question? And it's a double-edged sword. So if you tell me you're looking, I'm going to use the previous example as for appendicitis. If you tell me you're looking for appendicitis, obviously I'm looking for that. But then I miss other things that might be there as well, because I'm very focused on answering that clinical question. So the flip side of that is sometimes they will tell you nothing and say, I'm not going to tell you what I'm looking for. I want you to look at everything because I don't know what's going on. And so then you start mentioning things that may not matter at all because you don't know what the clinical history is. And so if you can get information related to why is that patient there and what in particular the ordering provider wants from that information, that's the biggest key for me. What's their clinical history and what is the question? And bringing those two things together is most helpful.
That seems to be a critical place to start. Before I move on, anybody else have an example of missing clinical context, which creates suboptimal interpretation? All right. Well, Scott, let me bring you in. How do we make imaging information actionable? If a radiologist could routinely see what happened 6 months after a study was done, what would they learn? Is the biggest problem interpretation, follow through, or visibility into outcomes?
Yeah, David, that's a really good question. And I think I might bring it up to like the 30,000 or the 100,000 foot level. And when I look at systems and when I look at like how healthcare kind of just flows, radiologists touch every single aspect of every specialty that's known. So whether it's primary care to transplant to GI to pulmonary, they touch every single aspect of all the subspecialties, along with like pharmacists. And so radiologists, having been integrated with radiologists now for the past 5 years in imaging, I kind of got a little bit of a different kind of context of the value of what imaging actually provides. And so when I look at it not necessarily from a one-to-one kind of read of the information and everything, but I look at it from the population perspective. And when I look at the population and then integrating the specialty societies along with imaging, there are so many opportunities out there where the system can really truly develop like really good outcomes, I think. And so let me give you an example of something. So the first one is from a patient that has cirrhosis. And when you have cirrhosis, you're supposed to get every 6 months ultrasounds to look for hepatocellular carcinoma. And so if you're looking for that, when for me, I'm used to looking at claims being in delegated medical groups or maybe at the health plan level, but there are so many subspecialty societies that have imaging associated with their guidelines. And because of different organizations, certain aspects are in fact kind of more important, the maybe diabetes outcome, but there are so many 400, maybe 500 plus imaging recommendations that may or may not be attained. And so the cirrhotic getting every 6-month surveillance for hepatocellular carcinoma, or diabetics that fail a FIB4 that should get elastography, I'm not sure if all of that is being accomplished within the system perspective. And so I think radiologists play a very, very, very important role in integrating that overall 30,000 foot level and knowing like, hey, this ultrasound is kind of due in 6 months, and we need to integrate with the GI, the hepatologist, and the radiologist as a team. And that's where I think we can improve outcomes upstream within the radiology confines, and then downstream with optimal screening, surveillance, et cetera, for the population.
All right. The next thing I was going to ask was again for Larry. And it's a follow-up to what Arnie just said. So Larry, how the radiologist's relationship to the clinical team has changed over time. Are we more or less connected to downstream decision-making?
Yeah. I think it's a double-edged sword. So I think in many senses, we're less connected. As we've moved to electronic imaging and a PAC system, no one visits the reading room anymore. It used to be standard in the morning, you'd walk down and you'd converse with the radiologist and get a sense of what's going on. It helped with clinical interaction, communication, information sharing. And essentially all that has gone away. No one comes to the reading room anymore. But there are new opportunities with more of the different communication methods, such as what we're doing now on video calls. A lot of tumor boards are now available. It's easier to connect with people in many ways during parts of the day, to the point where I know some radiologists won't do tumor boards anymore because there's such an ongoing and increasing request to be involved, because it's so easy to just click a button and join multiple tumor boards a day, as opposed to going to one in the morning and then starting your day. So I think it's a double edged. We have less communication and face-to-face interaction, but we have more electronic interaction, which can be helpful in patient care as well.
No, that makes sense. And that's a good segue for David Nash. When you think about imaging and population health, where are the biggest missed opportunities for imaging to be embedded in, included in, and add value to population health initiatives? And are we using imaging primarily just as a diagnostic tool?
Sure.
Or is there an opportunity for it to be a strategic tool for identifying risk and more influence of long-term outcomes? What would need to happen for imaging to become more intentional in population health strategy?
Wow. Well, first of all, great to be together, and thanks for the invitation. Really amazing group here. So this is awesome. And also day 2 of my departure after 35 years at Jefferson. So wonderful. So I've been listening carefully to these great answers, and all these guys are, experts, but here's the sad reality. And I'll tell 2 stories to illustrate the reality. So, and they both involve me, so there's no permission needed. So I've had 2 spinal fusions. The most recent one was 3 years ago. I'm very lucky to have outstanding neurosurgeons at Jefferson. I had a redo. It was a big procedure all day in the operating room, super expensive, 6-month recovery. I go from my immediate 2-week post-op film to make sure the screws are in the right darn place. And I have to go to a separate radiology part within our healthcare system of Jefferson. They don't know who I am. I have to pay a $35 fee, 2 weeks post-op, and then I have to wait somehow magically because this was outpatient, not inpatient. You get the idea. So there's total lack of aligned economic incentives to produce a population-based outcome. Everybody is in his silo doing his thing, probably doing it well, but there's complete lack of connectivity. So at least for something like a surgical care like spinal fusion, why don't we have a single bundled fee wherein everyone will be aligned both economically and clinically? And notice I said it in that order, to make sure that people are talking to one another. Second example, I'm on active surveillance for a super low-grade prostate cancer, and this is very common in the US for guys my age. So I get a PI-RAD MRI every summer, total lack of connectivity, different team reading it every time. They don't even talk to my urologist. In fact, my urologist has told me I'll probably get the result on the Epic My chart before he does. Well, again, that doesn't produce a population-based outcome. There's no registry to let us know how are PI-RADs read at Jefferson versus the Great Mayo Clinic, who's involved, what's our normative scoring system like. So basically, I think it's a diagnostic tool at this point, very akin to the 10 years I've done on the laboratory side, where they have many of the same issues. People order tests, the fantastic pathologists and super subspecialized laboratory medicine doctors do their thing, very little connectivity. They're experts. Why don't we ask them what's the appropriate test? And on we could go. So I'll summarize. Without a bundled payment, you will never fix the problem we're discussing. That is the cornerstone challenge, because there won't be any cooperation until everybody's wallet is connected, as it is in certain amazing group practices, largely run by doctors like Mayo, Geisinger, Guthrie, and a handful of other places. In the real world, at 150 major academic medical centers in America, it's a completely siloed activity. Now, your second question is really interesting, and I'm not an AI expert, although I'm learning every day. The tools that will be available to us to risk stratify and then instantly close the feedback loop. So I see the confluence of three streams of data. One is the radiology diagnostic stream of data. So we'll call that the EMR stream. The second is going to be clinical decision support tools like Open Evidence and UpToDate that have been AI enabled. And the third will be the workforce AI enablement that's iterative and can actually, start to think and produce changes in workflow, so that when a lowly primary care internist like me gets into the office and says, okay, what's going on here, I could see this confluence coming together and offering me advice about the next step as it relates to a radiologic test. So I'll summarize. Without bundled payment, none of this is ever going to happen. And number two, maybe with the confluence of these three data streams and that is sort of, learning as we go, I think we'll see certainly some marginal improvement with risk stratification, patient selection criteria as two of the sort of key areas that I think about.
Completely makes sense. Easier said than done.
Indeed.
But right now, and I was talking to Scott about this the other day. Scott, right now, would we be able to make care gaps more visible through imaging that are remaining hidden?
Yes.
I think that's one of Dr. Nash's,
Definitely.
I guess, pathways and everything, one of the
Yeah.
three areas. I think that, based on these subspecialty societies, we have to be able to make these things visible to primary care physician, to the gastroenterologist. And I also agree that there are some bundled payments that are out there. Some health plans offer bundled payments within their organizations. And you know what? They're effective. I have to say that. But having these gaps in care and having it within like the AI component, there's just too much information out there for any practicing physician to understand at this point in time, to have a comprehensive understanding of all the recommendations at every society. And so you're going to need to have that additional information and expertise to have it put forth. I mean, Larry's a neuroradiologist, and I see quite a few people that slip through the cracks with MS that need their annual MRI and CT, C-spine. So I think bringing these gaps to care within the EMR or within other components there to say, look, all these patients need all of these imaging studies and getting them accomplished, because the best AI doesn't have any value if the patient doesn't come in to get the scan done. So that's where I think all that upstream information is very important.
Could I jump in here? Because Scott, really, that was an awesome answer. And I'm just sitting here thinking about my own 2 clinical vignettes. Imagine if you really had a agentic AI working behind the scenes on the workflow, just coordinating the post-spinal fusion care. What about getting an annual reminder? It's time for your PIRAD MRI. Oh, and by the way, I've already connected your urologist and radiologic team, so they're standing by. And then we just have to decide whether you should get contrast or not based on the results you got a year ago.
Absolutely. I think that's
really doable, but there's no economic incentive to do it today because everybody's siloed off billing on their own diagnostic work.
absolutely. I think that's so key, are these silos. And I think the AI can break down those silos and being able to connect everyone together kind of seamlessly in order to get the best outcome. Because I think about having been in delegated medical groups where I had significant fiduciary responsibility. And I think about providing care at the lowest marginal cost. And that means that we want to identify disease as early as possible. We want to have disease that is being monitored according to guidelines and being able to identify where that progression happens. And now with AI, we can then stratify those members to say these members are going to be at the highest risk stratification, and these members, they may not be as high risk. So there's so much to do for kind of imaging 2.0, 3.0. I think it'd be fascinating. It's fascinating times.
I think we're talking about 2 or 3 different places where there's breakdown and there could be a lot of improvement. I don't think we have ideal information flow, but is that because the incentives aren't aligned in order to complete the information loop? Or is AI going to make it so that that's a lot easier to do? Is it revenue, and whether it's fee for service or value-based models of reimbursement, it still seems like we could set up that feedback loop so that we had the right information in the right place at the right time to take the next best action. But what am I missing? If it was easy, we'd already be doing it. Anybody?
Well, 2 of my AI consulting clients who are super smart, way smarter than me in this, and for the docs who are on this great panel and who are listening, I'm privileged to work with some physicians under 35 who have left or just completed residency in their clinical area and are going back to get a doctoral degree in AI. It's like, Arnie, it's like those Stanford business school kids who leave school to go build a company. It's very analogous, except these are physicians. So they're getting their hands on the workflow as a way to reduce burnout. So, think about this. If you can convince systems and system leaders to integrate using agentic AI as one way to reduce the burnout that we all feel, this phone call, this competing priority, I'm in the OR, I can't answer 14 patient emails, but a highly integrated, well-trained clinical decision support agentic AI can stratify those emails, send out appropriate links, start the process while everybody is doing his or her procedure. And then there's a way to close the feedback loop. I think you really hit it, David Gorstein. If we knew more about the outcomes of what we were doing and actually tracked that and gave doctors good information about their performance, I've always believed, and the research literature supports it, then you got to get out of the way because doctors will stampede to do a better job. That's what we're all about. But if you don't give us good information, the data is one thing. Actionable information is really what we're talking about here. We really lack actionable information. It's almost impossible. And I was listening again carefully as a internal medicine inpatient tending for 18 years, 2 months a year. I mean, we always brought the team into the reading room. Those days are gone, right? So that's a great closure of the feedback loop right there, right? And now without that, so we need to improve the workflow, take what was really great about sitting in the reading room together, the essence of that. We could certainly digitize all of that. We could record it. We could have it reviewed. We could distill what are the key take-home messages every time you see a film like this or like that. I think this field is poised for a really, I hate to use the term, but for a paradigm shift. I mean, this kind of nonsense, call me back, I got the results before you did, that has to go away. And that, I think, I could make an economic case, I could make an improved outcome case, and I could make a reduction in burnout case. So I think forward-looking organizations are already working on this.
Let me step in with a quick question to that specifically, because typically if something isn't already in existence, there's some kind of resistance to it. Help me understand, where would there be resistance to moving to this paradigm shift, as you mentioned?
Well, I'll let the radiologist give you their view. I'll give you my view. Anytime you threaten the status quo, there's going to be resistance. I mean, we know this since the 1500s. So you're threatening the status quo. I mean, why should I change what I do? I'm an expert at it, and I'm not going to change. Go visit the doctor's parking lot. Why would anybody want to change what they see?
I can answer that from a radiologist standpoint, and that is, I agree with what you're saying, Dave. It's a good insight, but yeah, adoption and change is always challenging, especially in entrenched systems.
Sure.
Radiologists, there was a period of my time in practice where we didn't really have any meaningful metrics to measure radiologist performance other than just basically the revenue of the group. I was a private practice radiologist in a group of 10 to 15. We eventually became 20. Over time, what happened, we started to measure each other on the basis of what are called RVUs, or relative value units. That's basically the intellectual input and the time required to interpret an imaging study. And we would have a daily monitor tracking everybody's RVU generation in that day. And so what happened was basically all of the measurement of the radiologist had to do with productivity, right?
Right.
Now, what did it not have to do with?
Outcome.
What it didn't have to do with was time to diagnosis, the effect on treatment decision-making in clinical practice of medicine, and the effect on patient outcomes. Okay. So with a value-based system, these metrics that I just laid out are much, much more important in terms of the well-being of the system as compared to individual radiology productivity, because they directly impact what is the ultimate product that system is trying to create. And then one last point regarding what David said, which I highly agreed with, which is that for us, what we're building at Stanford is a way to deal with a bottleneck in the practice of radiology, which was accessing patient information in the electronic health record and getting a contextual summary of that patient, right? And that was a huge bottleneck in my practice. And the reason why there's a massive interest in the adoption of this is because everyone feels it viscerally. And it's what I call high friction, low benefit work. And so the more that we can use AI as an assistive technology, maintaining the human in the loop, that will be a major impact on the provision of care by radiologists. And it will derive these outcome metrics that I'm hoping to create on the value side of healthcare delivery.
David, if I could chime in just very quickly. The way that I see AI working in the future is through efficiency and taking all this information and efficiently categorizing it, cataloging it for me. And so having the ability not to make asymmetric information decisions, but to make the best decision that I can based on even more available information that's there. I mean, I just had a 2048 page medical record sent to me. And usually I would come in, I would scroll down and I'd be like, oh, yeah, and I'm trying to find like the creatinine in this one thing. You know what? I press my AI assistant and boom, within 15 seconds, I have a full summary of this medical chart that was 2048 pages. So I think the efficiency of AI and bringing all this information together in a stratified modality is like the next generation for within radiology, but then for the larger system. So,
No, I think AI is going to help us have the right information in the right place, which will lead to better decisions, better outcomes. And that takes the whole village. It doesn't happen in silos, and if we can break down those silos using AI, I think David Nash's point is still valid. And we're gonna have our earliest traction in organizations that are on the hook for total cost of care.
Totally.
And that really is, I think, setting us up for the next chapter is how do we set up better information flow, better workflows, and a better reimbursement model. And those were my takeaways, but let's go around the table one more time for anything else that I missed.
I'll throw a question out. I'd love to hear the answers to this. What outcomes? I mean, I know what outcomes we have with like Medicare stars, MIPS, things like that. But in some aspect, I think they're limited in what real true outcomes are. I know we get hit with readmissions and admits per thousand, bed days per thousand, et cetera. But what outcomes would be the optimal outcomes to measure?
Yeah, well, certainly not everywhere in radiology, but diagnostic accuracy, that would probably be a good place to start. And Larry and neuroradiology, I mean, super duper subspecialized. But within that, we know that high volume, high surgical volume neurosurgical programs get better outcomes. They are assisted by amazing neuroradiologists who know what they're reading. These are super complex procedures. So diagnostic accuracy, which you it's very tough to do, even on a regional level because of competition, but probably could be done at the subspecialty society level. We know that there's great variation, but there's been very little energy to try to reduce the variation, except maybe in certain centers. The National Cancer Institute and all of their centers, they do benchmarking within radiology for cancer. So that's another avenue. But you're right. I mean, because we never really had to measure the outcomes, we didn't do it. Of course not. Why would we? So with the economic emphasis to really get on the value road here, I could think of lots of measures that make sense to the clinicians. That's really the key. RVUs, Arnie had it right. It's just a productivity measure. That's a hamster on a gerbil on a wheel. And it says nothing about your accuracy, your empathy, your skin to skin time in an invasive radiologic procedure, all of that. I mean, we could do a better job on all of these things.
And that's what I always tell the trainees. I get excited about AI because I think it's going to make us better, which is the most important thing of all, but it's also going to make us faster, to Scott's point about efficiency. I think those things, and radiology, I think, has to lean into that. A long time ago, one of my mentors told me, Eckel, the problem in radiology is we're becoming more imagers than physicians, and we need to be physicians. And it's true. We have to be part of the team and be involved in patient care.
I'll take that. And I just go back to what I said earlier, which is the metrics that really matter in terms of patient care are time to diagnosis, impact on medical decision-making, and then ultimately patient outcome. And radiology has an outsized role in all those things now.
Absolutely.
We just have never measured it. And if we can create the metrics that effectively show the value that we're bringing, that's the future as far as I'm concerned for a value-based system like David described.
At the end of the day, seems to me, and other people have certainly described this better than me, because we have a fee-for-service car chassis, we could change the sheet metal, we could have fancy headlights, leather interior, do all the value stuff, but we're still driving on a fee-for-service chassis. So we got to get rid of that. And once you change that, then everything is possible. And I think it would improve value, improve outcome, certainly make patients happier, would reduce burnout, but it would challenge the status quo in a big way.
Oh, David, I was going to say one thing. Arnie, one of the things that I think of when I look at populations is that when I see somebody that presents, and I do a lot of medical review, presents with metastatic cancer or presents with advanced cancer, I feel that that's like a failure within the system, right? The time to diagnosis should have been done with that mammogram maybe 5 years ago or whatever. So when I look at that time to diagnosis, I think that's a very important consideration. And we really don't have any outcome measures for that. And I think getting people in, getting them to the appropriate radiology or imaging done, that time to diagnosis is exceptionally important for everybody within the healthcare system.
Yeah. So Scott's right. I would just add there's 30 plus years of research on what we came to call disease trajectory, disease staging. I mean, there are people who are still alive and working who created various models to look at trajectory, risk stratification, Hopkins, Jefferson, elsewhere, but they were off in health services research centers, not really connected to the operations. But Scott, I think we could certainly make a strong case today with 95,000 employed doctors. It would be kind of cool if Optum and United led the way on figuring this out. I would argue they have a unique market opportunity, but I don't really see them rushing to embrace making this kind of change.
Yeah, I'll just say, but many times with the specialists, those specialists are still on the fee-for-service chassis.
Oh, right. They're driving fast on that chassis. Yes, they are.
Well, I want to ask you a question, Dr. Howell, specifically about Imogen and how some of the things that Imogen is doing to sort of move us forward. Can you kind of give us a little bit of insight there?
I can only talk on the population health perspective. I'm not a radiologist. I'm just on the front lines from a medical perspective. And it's about integrating all of these aspects that we kind of talked about. For me, knowing like the time to diagnosis and integrating the specialty societies and looking at where those gaps in imaging aspects are. And then there's a whole different subset within the actual radiology component. And I think Larry is probably better to look at it individually, but I just represent the population health aspect to it. And there are the items that I care most about is getting people in, getting people having the right diagnostic imaging done, and then following those outcomes out and making sure that we can do things for the system at the lowest marginal cost, and then having the best population that we can, the less severe disease states that are out there. So, but I can't talk on the radiology side, and Larry will have to talk about.
Yeah. So thanks, Scott. I think Imogen's mission statement is the right diagnosis at the right time. And I think that's what this is all about in many ways. Because when someone gets I'm going to make it up now, a chest radiograph, if you don't get the right diagnosis at that right time, they're going to go down a completely different pathway that's going to be a waste of their time and resources and perhaps their health. So you want to get the right diagnosis, and that's what it's all about. And that's where AI can come in. That's where time to read the studies in the appropriate clinical context that we started out with this discussion with. And then the appropriate economic motivators for that. Not a lot of radiologists want to read a plain film X-ray anymore. They all want to read CT and MR and PET because that's where the revenue is. That's David was talking about. So to align all the financial incentives with trying to do the right thing to get the right diagnosis at the very moment the patient comes in for care really can change the trajectory of everything.
It strikes me that we have several radiologists on this call who are all in on this concept of radiologists being more consultative and really part of the care team so that there's visibility into what happens after the study, one of the follow-up, and then closing the loop on what's the next best action. And I think there are probably a bunch of radiologists out there who are banging their head against that WRVU wall who would like to be part of this discussion about how we really can all be part of care delivery ecosystem and not this fragmented looking system we have now where radiologists just read studies and have no idea what happens next. So that's what we're working on our end, is trying to find those radiologists, even if they're not doing it now, that have curiosity about it. David Nash mentioned it's the same thing on the laboratory side. My dad in Diagnostic laboratories at Jefferson, he just retired a couple of years ago, even though he's much older than David Nash, stayed working for a long time. He often said, half of what we do in laboratory medicine is unnecessary. I wish that I could ask every referring physician, why are you ordering this test? And what action are you going to take based on the results of this test? And if you can't answer that question, then maybe you shouldn't be doing it. I think that applies in radiology as well.
Absolutely.
Yeah. No, David, I think a lot of people think a radiologist is just some weirdo in a dark room. We all went into medicine, I think, for the same reason as everybody else. We want to help patients as much as we can. My favorite thing of the day is helping a clinician get the right answer. That's what gives me the biggest charge. And when all those things come together, that's beautiful medicine. And that's what everybody wants every day.
So well said. Well, I think we want to maybe wrap here. This is the first of more conversations to come, and certainly we'll have some of our guests back that were here today and others to come. Once we get this posted, we're going to ask everybody, please go ahead and leave your questions and comments and feedback in the comments so that we can continue the dialogue and move it forward. So thank you all so much for joining us. This has been a true pleasure, and I'm excited to see where this conversation continues to go. We appreciate you so much.
Thanks again.
Thank you.
Thank you so much.
Thanks. Good to be on the team.
Learning a great conversation.
Thank you.
Bye-bye.